Hi everybody, it's time to talk about sexually transmitted infections. This is chapter 74 in your book. So sexually transmitted infections are caused by infectious microorganisms. They pass from one person to another through many different routes, but intimate contact all the time, by oral, vaginal, anal intercourse. Sometimes pregnant women can pass a sexually transmitted infection onto their child. Sometimes they can be passed through blood or fecal-oral transmission. If the sexually transmitted infection continues on a chronic basis, then we use the term sexually transmitted disease. So the top 3 sexually transmitted infections in the United States, according to the CDC, and this is newer, or the newest that I found, is HPV. That's number 1, followed by chlamydia and gonorrhea. So STIs or STDs can cause tremendous suffering through pain, scarring of genital urinary structures, damage to other body organs, infertility, birth defects, nervous system damage, cancers, and even death of infected individuals, and sometimes even their children. So these infections or diseases have profound effects on people, families, relationships, causing depression, loss of self-esteem, feelings of shame, and avoiding intimacy. So all of those things, including guilt over passing on some kind of possibly incurable disease, or feelings of betrayal by a partner, are only part of the emotional consequences of sexually transmitted infections. So again, they are passed from one person to another through intimate contact. Some organisms are transmitted only through sexual contact, where others might be transmitted through blood or fecal-oral route. Mom to fetus, mother to newborn, that type of thing. So who is at risk? Is anyone at risk? STDs are a major public health concern worldwide, and I think I mentioned this already in class. Those at greatest risk are pregnant women and adolescents and men who have sex with other men. So it's been found that over 50% of newly diagnosed sexually transmitted infections in the United States at any given time are among people who are 25 years of age or less. So teenagers may be having sex at earlier ages. There are sexual abuse cases, sex trafficking, international, just traveling, all contribute to STIs. American culture is at risk because we tend to hide sexuality. There's a stigma around STIs and STDs, and we certainly don't want anybody to know if we have that type of infection. There are certain STDs and STIs that have to be reported, and included in those are chlamydia, gonorrhea, syphilis, HIV and AIDS. They all have to be reported to local health agencies in all states. Genital herpes has to be reported in some locations, but not all. And as you, I'm sure, know already, all reports have to be kept confidential. Safe sex practices are using condoms for genital and anal intercourse, wearing gloves for fingers or hand contact with vagina or rectum. Abstinence is the best method of not transmitting any type of disease. Mutual monogamy among partners, meaning just having the one partner. Decreasing the number of sexual partners. So all of those are safe sex practices. So everybody is susceptible to these diseases. And don't think that just because someone is in a certain occupation, or they're in a certain economic group or a certain culture, that they are more or less prone to contracting a sexually transmitted infection. So the primary tool for preventing sexually transmitted infections, aside from safe sex practices, is educate, educate, educate. And it's possible that we don't do near enough education in our public schools with our teenagers, our teenage population, so that they know how to prevent these types of infections and diseases. So I put this on here because, it's really difficult for some people to talk about or even mention the word sex. So the more open we are with our children, the better off we are, and the more likely we are to prevent our children from getting infectious diseases of any kind. So in your book on page 1505, table 74-1, it lists complications caused by contracting sexually transmitted organisms. A big one for women is pelvic inflammatory disease that's included in this chapter. Some that I have on this particular slide are not mentioned on this particular table, but there are probably others that are not mentioned in either place. So that in your book, the first thing they talk about is genital herpes. Genital herpes is an acute, recurring, and be noted that it is an incurable viral disease. Your book says, and this is dated, this book is a little older, it says it is the most common STI in the United States. But that is not true according to what I found from the CDC. It is currently genital warts, or HPV. So there are two types of herpes simplex virus that affect the genitalia, type 1 and type 2. Most non-genital lesions like cold sores are caused by herpes simplex virus 1. And so we get that from oral to oral contact. So kissing somebody, using their toothbrush, drinking out of their glass, we could get, that is how that is transmitted. Historically, herpes simplex 2 virus has caused most of the genitalia lesions. However, this isn't true anymore. Both can cause oral or genital lesions through oral genital or genital contact. So recurrences aren't caused by reinfection. However, they're caused by viral shedding. And the patient or the client, the person, is infectious. Even if they don't have lesions, they are still infectious. Recurrences can be caused by stress, fever, sunburn, poor nutrition, and of course, sexual activity. That's what we're talking about here, is sexually transmitted infections. Most people aren't diagnosed with this because they have mild symptoms and virus sheds intermittently. So sometimes, if you don't see a lesion on yourself or someone, sometimes you don't know that you're ill or that you have an infection. So again, herpes simplex viruses, type 1 and 2. These types of microorganisms, these viruses, like skin, and they like nervous system. So they lay around and they're just taking it easy in the nervous system tissues, and they reactivate periodically when a person is, again, under stress, or their immune system might be compromised at any given time. So again, historically, the herpes simplex virus 1 has caused oral lesions like fever blisters of the mouth, but again, can cause genital herpes as well. And herpes simplex virus 2 historically has caused, or we have always considered it the quote-unquote genital version of this herpes virus. But again, they are interchangeable. So some people, again, that are infected with herpes simplex virus show no noticeable symptoms, but they shed the virus and transmit the disease. There is no cure for herpes infection. There are antiviral medications like acyclovir that can be given to decrease the severity of the symptoms. However, again, the person still can shed that virus. Testing for herpes requires a special viral collection kit, whereas they swab or scrape the specimens and send it off to lab. So this is just a picture of an example of what a herpetic lesion looks like on the skin. This isn't on anybody's mouth, or it's not on the genitalia, it's just on somebody's skin. This, on the other hand, is herpes simplex virus affecting genitalia. And you know me, I always like this kind of stuff. Back in the day when I went to school, we had books in first grade when we learned to read called the Dick and Jane books. And somebody just ran with it here and made this promoting protected sex. So like use of condoms, that's what they're promoting here. This is herpes on the anal area. This is another herpes infection on somebody's skin, only this is from herpes virus simplex 2. Herpes simplex virus 2, sorry. So how do you diagnose? Again, it's based on history and a physical exam. And again, those viral cultures or scrapings of the lesions and sending it off to lab. We assess if the client felt itchy or had a tingling sensation in the skin 1 to 2 days before an outbreak. And that is called a prodromal stage. These sensations are usually followed by clusters of blisters on the penis, the scrotum, vulva, vagina, cervix, or perianal area. The blisters rupture and they leave painful ulcerations. Other symptoms might include headache, fever, just general malaise, swelling of lymph nodes, if somebody has lesions around their genital area, which is what we're talking about here, genital herpes care, they may have urinary retention because they don't want to pee because it hurts. So they may need to have a urinary catheter placed to help with their elimination. Usually the lesions resolve within 2 to 6 weeks, and that's a long time to put up with painful blisters. So as far as treating them, we want to keep them comfortable because the lesions and ulcerations are painful, so we want to decrease the discomfort. Antivirals can decrease the severity of symptoms, but again, it will not cure the infection. Topical therapy is not recommended. The most common medications that you will hear about, and you might have already seen advertisements on television about them, are Zovirax or acyclovir and Valtrex. In the past, I've seen Valtrex commercials a lot. There's also Famvir and Avarax. So what's the difference in all those? Well, they're all antiviral medications, but the difference in most medications, just like any medication, the cost and how frequently they need to be used, those are really the big differences. But they all treat viral infections. Syphilis is the next thing. Syphilis is a complicated sexually transmitted infection that can become systemic and cause very serious complications, including death. And I have some pictures on here that are very intense. So you'll see how this little microorganism, this little spirochete, can cause horrible disfigurement in people when it's a chronic situation. So the syphilis microorganism is called Treponema pallidum, and it's a spirochete. I'll show you a picture of that. So the syphilis progresses through 4 stages. There's primary, secondary, latent, and tertiary. So you need to know the difference and the symptoms that go along with each of those stages. The first sign of primary syphilis is a canker. Canker formation is the only symptom. And it's just like this, it develops at the site of the entry of the microorganism from 10 to 90 days after exposure. They can be found on any area of the skin or mucous membranes. But they are a painless, indurated, smooth, weeping lesion. So this is a highly infectious stage. And that canker begins as a tiny little papule, but it just continues to grow and weep. So without treatment, the canker usually disappears within 6 weeks, but the organism spreads throughout the body and the patient is still infectious. So just make sure that you know that the canker is a painless, indurated, smooth, weeping lesion. Not necessarily painful. It says it's painless. It's not painful. So secondary syphilis then develops 6 weeks to 6 months after the onset of primary syphilis. So in that secondary stage, syphilis is a systemic disease because the spirochetes, those little microorganisms, have been circulating everywhere in the bloodstream for all this time. So the person starts to feel like they have the flu, possibly. And just think of how long this infection has been going on. And this is a serious infection. And they don't know they have it. They just think maybe they have the flu. So it's commonly mistaken for flu because there are flu-like symptoms like a low-grade fever, a headache, myalgias, muscle aches, sore throat. But they do get a generalized rash. And if you look in your book on page 1508, there is a rash on the palms and soles of the feet that is typical for that secondary syphilitic symptomology. After the second stage of syphilis, there's a period of latency. Early latent syphilis occurs during the first year after infection. Late latent syphilis is a disease of more than 1 year's duration after the infection. And it's not infectious except to a fetus if a woman is pregnant who has syphilis. The last stage is tertiary syphilis. From 4 to 20 years later. So this stage develops in untreated cases and can mimic other conditions because any organ system can be affected with syphilis. So the primary tool here for prevention, once again, is education. So you just make sure that you know the primary, secondary, latent, and tertiary stages. Primary stage, again, there's a canker. That's the first sign of syphilis, and it's a painless induration on any area of the skin or mucous membrane. It's a highly infectious stage. Secondary syphilis is systemic because the spirochetes have been circulating throughout the bloodstream for such a long time. Again, they have flu-like symptoms at this time, and it's just commonly mistaken for having the flu. So in the secondary stage, they have that typical palm and sole of the foot rash on, so the soles of their feet, the palms of their hands. So it appears as a macular reddish-brown papules or pustules. And in your book, they look really scaly on that. They look like psoriasis almost. So all of those lesions, just so you know, should not be touched without gloves because they are highly contagious. So in the latent period, which is the next one after the secondary rash stage, that third stage is not infectious except for pregnant women. They can pass syphilis onto their fetus. And then that tertiary stage develops from 4 to 20 years later. And the signs and symptoms are the benign lesions of the skin, mucous membranes, bones, cardiovascular system like the aortic valve. People develop aortic aneurysms. So in this stage, it can affect any organ system of the body. And this is the spirochete. That's what it looks like. It's kind of like looks like a spiral on one of those things on a spiral notebook. So you can't really see this maybe very well, but this is the cankers in the primary stage of syphilis. They kind of look like they're open and red, and they may be weeping, but just remember that these are indurated areas. They're just raised areas. This is what is called a gumma, G-U-M-M-A, and these develop in the later stages of syphilis. And this is also a syphilitic lesion that has some drainage on it. I like old things, like antiques and such, and so when I see things like this that they used to use in the olden days, I kind of collect this kind of stuff. Not like I put pictures up in my house or anything, but I kind of like how they used to promote education for what they used to call it venereal disease back in the day, not sexually transmitted infections. They were called venereal diseases. So they were trying to do campaigns to get people to understand that they needed to, abstain from sex, that type of thing. So I just think that this is kind of interesting how they used to go about things in the past. So they would hang these things up around town, or advertise in the newspaper, that type of thing. So here again are the syphilitic skin lesions, and again these are infectious. Like, you should not touch these without gloves. They're contagious. Again, typical secondary syphilis with palmar rash on the hands. So how do we take care of these individuals who have syphilis? So the blood tests that we do, on page 1509, it says the healthcare provider obtains a specimen of the canker for examination under a microscope. So diagnosis of primary or secondary syphilis is confirmed if that little spirochete is present. So what you need to know also is the blood tests that are used to diagnose syphilis. And the usual screenings are called Venereal Disease Research Laboratory Serum Test, or a VDRL, and then a rapid plasma reagent test, so a VDRL and RPR. So if your patient in clinical, let's say you have a patient in clinical, and they're maybe a little bit older and they're developing heart problems or some other type of issue with any of the organ systems, and the physician feels like, well, I've done a history and physical on this person, and they have had, multiple sexual partners in their past, or whatever the case may be, you may see that they order a VDRL and RPR for this patient, to see if they have syphilis. So just keep that in mind, that you will see that many times it is not uncommon. Because just think of when the tertiary syphilis kicks in maybe 20 years. That's a long time. And somebody could have developed a number of chronic diseases by that time. So these tests are based on an antibody-antigen reaction, and it'll determine the amount, the presence and the amount of any antibodies produced in response to that spirochete. Tests are reactive 2 to 6 weeks after the infection. is obtained by the patient. If a VDRL is positive, then more specific tests can be done to confirm diagnosis. Treatments. So I've mentioned before that we use penicillin G for a lot of sexually transmitted infections, and this is one of them. So it's given IM for primary, secondary, and early latent stages. And just remember that penicillin G it's very thick. We give like I think it's 2.4 million units. That ends up being at least 2 IM injections in a big muscle, and we have to give it with an 18 gauge needle because it is so thick, or it wouldn't go into the person's body. So there are people who are allergic to penicillin. So always, if you give something, make sure that you're monitoring the patient for several minutes after you give them penicillin. Monitor for a rash, shortness of breath, chest tightness, anxiety. Keep all patients in the clinic for at least 30 minutes after administration of penicillin. So after treatment, then they'll bring the person back in and they'll do more blood tests in several months, and repeat treatment may be needed if the patient did not respond to antibiotic therapy. So all sexual partners need to be prophylactically treated, preferably within 90 days. So the bottom line, again, is educate, educate, educate. Sexual abstinence until the persons are treated. They need to keep their follow-up appointments, and we report to local health authorities incidents of syphilis. So somebody who has like chronic syphilis for a long time, so it can just eat you up. So the tertiary syphilitic pictures down there are faces of people who have had chronic syphilis. So it's very disfiguring, can be very disfiguring. Condylomata acuminata, or genital warts, caused by certain types of human papillomavirus. And again, this is the #1 sexually transmitted infection in the United States. And it's a primary risk factor for the development of cervical cancer. The most common types there's many types of human papillomavirus, and they're all numbered. The common types are 6 and 11. They rarely cause invasive cancer of the genital tract, such as cervical cancer, those most common types, 6 and 11. Patients can get multiple strains of genital warts at the same time. So you can see on the picture and on the PowerPoint, it says single small papillary growths that can grow into large cauliflower-like masses. And if you look at the picture there on, well, both of those pictures, they actually have like a ring of genital warts. The sites on the body that are generally affected include the urinary meatus, labia, vagina, cervix, penis, scrotum, anus, and the periarea. So basically anywhere on the genitalia. So again, this is the most common viral disease that's sexually transmitted and is often seen with other sexually transmitted infections. So how do we diagnose this? Well, we can see it, which is a nice thing about it. We can actually see the small white or flesh-colored papillary growths that can grow into these large cauliflower-like masses. The warts can actually disappear and reoccur on their own. There's no current therapy that eliminates HPV, like there's no medication that we can take. So the treatment is to remove the warts. So, and how do they do that? Well, they can burn them off. That's one way to handle it, with either electrocautery or liquid nitrogen. There are creams and gels available that can be used, but again, nothing is going to cure or eliminate that infection. They will still have the virus in them, even if they use the cream or a gel. On the outside, they've still got the virus circulating. Teach patients not to use over-the-counter wart treatments on genital tissue. You know, like wart for, let's say, a typical plantar wart on the sole of your foot. You want to tell people, do not use that kind of stuff on your genitalia. So there are over 100 known types of HPV. That's a lot. They can go away, as I've said before, and there can be a really long latent period, but they can certainly come back, and there is no cure. So we freeze them or burn them off or chemically destroy them. So Gardasil is the current injection. It's the current vaccine. It's from Merck. And it is a vaccine that is anti-HPV. It is recommended for males and females that are in their like 10 to 15 year range. Excuse me. So what this is for is basically to prevent cervical cancer. There's also one that has been available, but it's no longer available in the United States, called Cervarix. So this was by GlaxoSmithKline, and they didn't have a very big demand for it in the United States, so they took it off the market here, but it is still used in the United Kingdom. And here's just a bunch of pictures of genital warts. So education. Recurrence is likely, especially in the first 3 months. So if people can continually get these warts, they just need to go have them removed. But again, they're always going to have the virus circulating, and there's always the opportunity for those warts to come back. If they have, all of the sexual partners that they've had should be evaluated. And of course, use condoms to help reduce transmission even after the warts are treated. We've talked about Pap tests, and women get Pap tests to identify cervical cancer. So they should continue to get those Pap tests to make sure that they do not have cervical cancer from the human papillomavirus. And young men and women should get the Gardasil vaccination. The next infection that's mentioned in your book is chlamydia. Chlamydia trachomatis. So this is the causative agent for genital chlamydial infections. The pathogen can be present in the genital tract for months without producing symptoms. That's very important to know, that people can have this and not have symptoms. And again, I think I've mentioned this already in class, but that is why it is such a big concern in public health, because people don't know they have a disease or an infection, and they spread it. They spread it by contact. So that is why it is a huge concern. Chlamydia is reportable, once again, it's reportable to local health departments in every state. There are 2.9 million new cases every year. Another problem with chlamydia, not just that it's a big public health problem because it's asymptomatic, but 20 to 40% of women will develop pelvic inflammatory disease if they are not treated. And pelvic inflammatory disease can lead to infertility. So when you are, if somebody comes into a clinic that you're working in, you take a thorough health history, and you want to know about them. You know, do they have any vaginal or urethral discharge, dysuria, pelvic pain, irregular bleeding? Of course, this is for women. History of sexually transmitted infections, sexual partners with sexually transmitted infections, new or multiple sexual partners, unprotected sex. So that's all for women. You want to know if they have mucopurulent, like kind of a mixture of mucus and pus, mucopurulent vaginal discharge, urinary frequency, abdominal discomfort. So women might have more obvious signs or symptoms than men do. Men have frequency of urination and maybe a watery discharge if they have chlamydia. All sexually active women 25 years old or younger, and all women older than 25 years with new or multiple partners should be screened annually for chlamydia. Again, people need to be educated on abstinence after treatment and until all treatments are completed for both the women and the partners. So the treatment is Zithromax, which is or doxycycline, but the Zithromax is a one-day course. Doxycycline is multiple days. So again, just with chlamydia, women are at high risk for pelvic inflammatory disease, so they need to be rescreened for reinfection with chlamydia. One out of every 3 sexually active teenage couples has chlamydia. It's the #1 cause of infertility in America. It's the most commonly reported STI in most middle schools and high schools in the United States. Oops. So this would be really nice if there was such a great, if we could really tell that people had a sexually transmitted infection, but we can't. So a person is not going to be wearing underwear like that. So make sure that you have protected sex, or make sure you educate your patients to abstain altogether. The next section in your book is gonorrhea. And the microorganism is Neisseria gonorrhea. Again, the infection can be asymptomatic in both men and women, but women have asymptomatic or silent infections more often than men do. If symptoms are present, men usually notice painful urination and a penile discharge that can be either profuse yellow-green or a scant clear fluid. So men tend to seek help earlier, sooner, just because they have the symptoms, and by going to get treatment or help, they tend not to have some of the serious complications associated with gonorrhea. So the PowerPoint slide says women may have either no noticeable symptoms or have a sore throat, and MPC means mucopurulent cervicitis. So their cervix, they have this purulent mucousy discharge. They could have urethritis, abnormal menstrual symptoms like bleeding between periods. So I just want to mention that this Neisseria gonorrhea and many other sexually transmitted infections are developing into antibiotic-resistant strains. So we're getting to a point where these types of infections at some point may not be real treatable. So we may see even an increased incidence later on with infertility and such things as that. So gonorrhea can cause a pelvic infection, endometritis, salpingitis, or even peritonitis. Again, that's very serious. Men, again, often have more symptoms than women. Men's discharge can be yellow-green, scant, or clear fluid. If a person gets a fever, that's a sign that the infection is ascending or that they have a systemic infection. And what I mean by ascending is that it's not staying in their genitalia, it's moving up toward, let's say, maybe they have urethritis. And so it's going up now into the bladder and the ureters, into the kidneys. So it's not just staying there. So if a person has a fever, that could be a sign that the infection is traveling. So how do they diagnose this? They do molecular testing for the microorganism. Within 30 days of finding out whether someone has this or not, sexual partners should be examined and treated as well. And the treatment is Rocephin, or ceftriaxone, that's the other name for it, IM, plus Zithromax or doxycycline to treat presumed chlamydia infections as well. So usually these infections don't travel alone. There's usually two of them together. So that's why I just said they treat the gonorrhea with Rocephin and Zithromax or doxycycline. They treat the gonorrhea with ceftriaxone, but they add Zithromax or doxycycline to treat the chlamydial infection until it's ruled out, or unless it's been ruled out. Again, this is another reportable disease to the local health departments. And people need to be educated. Educate, educate, educate. On page 1513 in your book, again, drug therapy. Drug therapy recommended by the CDC is Rocephin, IM, plus Zithromax in a single dose, or doxycycline orally twice daily to treat a presumed co-infection with chlamydia. And again, that's unless the chlamydia has been ruled out. Sexual partners have to be treated, not just evaluated, to prevent reinfection. So here's just some of the discharge noted with gonorrhea. And again, these are mostly men because men have more symptoms than women. Here is gonorrhea discharge on a woman. So the next point in your book is the pelvic inflammatory disease. This spreads easily and quickly to other organs. So if it's spreading to other organs, other infections occur like endometritis, salpingitis. And again, ask yourself what these all mean. Oophouritis, parametritis. And look in your book on page 1514, and it kind of shows you a picture of the spread of pelvic inflammatory disease and with streptococcus and staphylococcus. So peritonitis, appendicitis. Remember that STIs are most often the infections responsible for pelvic inflammatory disease. Sepsis and death can occur if treatment is delayed or inadequate. Again, remember, pelvic inflammatory disease is one of the leading causes of infertility. So typically, there will be a dull pelvic pain and tenderness in the tubes, the fallopian tubes, and the ovaries. So in that region, in the pelvis, is where the woman would feel that heaviness and dull pain. Many women only experience mild discomfort or menstrual irregularity. If there's a lot of pain, you may see someone walking differently than they normally might walk, because it hurts to walk. So assess for signs and symptoms: an increase or change in vaginal discharge, painful sex, malaise, fever, chills, lower abdominal tenderness with possible rigidity or rebound tenderness in the pelvic and abdominal region. This is the picture that's in your book on page 1514. And again, just to reiterate, all sexually active women 25 years old or younger, and all women older than 25 years with new or multiple sex partners should be screened annually for chlamydia. So with pelvic inflammatory disease, they can get abscesses and all kinds of things. So they may even need a laparoscopy to remove the abscess and be treated with antibiotic therapy. So on page 1516, again, all sexual partners should be treated for gonorrhea and chlamydia infections regardless of whether they have symptoms. And this is to prevent pelvic inflammatory disease. There's an action alert on 1516. Also, instruct women who are being treated for pelvic inflammatory disease on an ambulatory care basis to avoid sexual intercourse for the full course of treatment and until their symptoms have resolved. Ask them to check their temperature twice a day. Teach them to report an increase in temperature to their healthcare provider. Remind them to be seen by the healthcare provider within 72 hours from starting antibiotic treatment and then 1 and 2 weeks from the time of the initial diagnosis. So again, why do we do that? We want to make sure that they are not getting further infection, they're not getting an abscess, and we want them to return to check on them because we want to prevent them from being sterile and having fertility problems with these infections. So that completes what is in your book. I just have a few other things on here that are, to me, interesting, and other things that you will probably hear about in your career. So I'm just going to just put them out there. So another infection is Trichomonas vaginalis, and it is this is considered a sexually transmitted infection normally, but it can also be transmitted through non-sexual contact with infected articles, because it can survive for a long time outside of the body. So some of the symptoms are frothy, foul-smelling, creamy to green colored discharge, redness, swelling, itching, and burning of the genital area, as well as pain with intercourse and voiding. Diagnosis is easy because the organism is large and distinctively shaped. And the treatment of choice for our trichomonas is Flagyl. And when you're treating a woman for this, the sexual partner needs to be treated as well. So here's the trichomonas, and it is a protozoan with a flagella. So it's got a little tail that it whips around and moves. So this is a differentiation between, I think, in the gynecologic, when I was talking about gynecologic stuff, I had bacterial vaginosis on my PowerPoint, but I don't think we talked about it very much because it's not in your book. But so you can do like a comparison here. So with trichomoniasis, the discharge has a musty odor. It's pale green, watery discharge. The trichomonas causes sex to be painful. It causes itchiness and tenderness and pain on urination. The vulva get reddened, and there are petechiae in the cervix. Like if there's an examiner looking there with a speculum, they can see petechiae. Again, this is very easy. Trichomoniasis is easy to diagnose because they can see that big protozoan type microorganism. And again, always treat the partners of somebody who has been infected. So this is a picture, and I just have to ask you if you can tell what this is. This is a cervix, and this person is infected with trichomonas. So I have a lot more stuff on here. I did want to see you about, or show you the trichomonas, or tell you about trichomonas. Let me see. I have HIV on here, but we're not going to cover that. But I do want to show you some lesions. You'll probably be talking about HIV in 435, but this is called Kaposi's sarcoma. And this goes along with HIV/AIDS. So these are some skin lesions that you might see. People also get them in their mouth. So they just look like big dark spots, like big bruises, but they're not bruises. People who are infected with AIDS, HIV, cancer, they can, when they get their chemo treatments and when they take drugs and antibiotics, they can get thrush. And this is just showing a picture of thrush with all this that you can see. I have antiviral therapy for AIDS on here, but we're not going to do that. But I will show you genital parasites, which you probably know about, pubic lice, which are commonly known as crabs, and scabies. We see outbreaks of scabies in nursing homes, and when I worked in ICU, we used to have outbreaks of scabies. It is a big deal. Scabies are gross because I think lice in general are gross. But these are easily passed from person to person just through clothing or touching people. So scabies, the females burrow under the skin and lay eggs and form tracts, and it causes extreme itching. So both of these parasites are diagnosed by direct to visual or magnified view. You can't really see the scabies, but you can. Pubic lice are big enough that you can see them, as you can see lice on somebody's head. So again, they're treated with topical insecticides like Lindane or permethrin, but I think Lindane has been, I think it's outlawed because it really worked. But they do have over-the-counter things that you can go buy at Walmart or whatever. So here's just an example of pubic lice, and there are some actual lice that you can see on that person. This is a scabie. I just think they are the nastiest looking things, and these are some of the skin tracking. It usually looks like little tunnels, little red tunnels, and that usually gets like between fingers and between toes. They like that, but this is kind of what it would look like from a side view. They're kind of like moles or groundhogs or whatever, but they get under the skin and burrow under the skin, and that's where they lay their eggs, and that's what makes it so itchy. Other things that we don't consider as like sexually transmitted infections, but they do affect the genitalia, or things like Candida, or this is a yeast infection from somebody just having too much moisture. Women can get Candida infections also in their genital area and also under their breast tissue. This is another form of a yeast type infection on a penis of a gentleman. So again, reporting. Just remember that not all STI patients are going to be adults. So there could be some childhood sexual abuse going on, so we have to be very cognizant of reporting and help gather evidence. Again, some forms of sexually transmitted infections may have been transmitted at or before birth, and later have presented symptoms. And you may have learned something about that in pediatrics. So this is just showing how young people account for a big portion of new cases of sexually transmitted infections. So the purple is ages 15 to 24, and the blue is ages 25 plus. So gonorrhea, the younger ones, actually in most of the gonorrhea, chlamydia, and HPV, and even the genital herpes, the younger ones account for more of those infections than syphilis and HIV. Unique factors that place youth at risk. Insufficient screening. So a lot of young people don't get the screening that they need because they're either embarrassed or they don't want anybody to find out. They have confidentiality concerns, so they're reluctant to come to the clinic. They don't want to tell anybody what their risky sexual behaviors are if they have them. Young women's bodies are biologically more susceptible to STDs and STIs. A young person may have a lack of access to health care because they don't have insurance. Maybe they don't live with their parents, and maybe they don't have their own insurance. Many young people have multiple partners. That increases their risk for sexually transmitted infections. So it is vitally important for clients to know about these diseases. People should be made aware that having a sexual relationship with someone is the epidemiological equivalent of engaging in sexual activity with all of those persons' previous partners as well. So just think about that. I mean, how well do you really know people that you are intimate with? Maybe they've had multiple sex partners, but they haven't told you. And actually, you are having sex. It's like you are exposed to those sexual partners or the germs that those sexual partners have given this person that you're now with. So you just have to kind of give that a thought. So here's another one of those antique marketing and educational posters. And again, we used to call sexually transmitted infection venereal disease. And people do not like to talk about sexually transmitted infections. It's kind of taboo. So don't play the sex lottery. Have protected sex. These are, of course, male condoms, but they also make female condoms. They make dental dams that some people use for anal sex, that kind of thing. I don't have a picture of one of those. Drinking impairs judgment and it reduces inhibitions, so someone might be more likely to have sex with somebody unprotected. This is another very risky behavior. So again, people should not share their needles. More risky sexual behavior. And then again, make sure you know if you're getting a tattoo, who's tattooing you, and make sure that you know, that they have sterile equipment and all of that sort of thing, because that's a good way to get Hep C if they are not sterile. So just make sure you know, to the best of your ability, who you're with, and educate your patients. So that's all I've got, and I hope that if you have any questions, you will send me an email. So thanks for listening.